All right, it is 3 o'clock, so we're going to begin our final session of the day. Our final presenter is Dr. Monique Anawis. She is the Medical Director and Health Equity Counsel for Illinois Attorney General Kwame Raoul, providing expertise on civil, criminal, policy, and public health matters. She served on the Illinois COVID-19 Crisis Standards of Care Working Group and chaired the legal subcommittee of the Illinois Crisis Standards of Care Project planning for mass casualty events. As faculty for the National Attorneys General Training and Research Institute, she lectured on opioid use disorder and prescription drug monitoring programs, and at John Marshall Law School taught health law. Dr. Anawis is an elected fellow of the American Bar Association and past president and fellow of the American College of Legal Medicine. She is past chair of the Illinois State Bar Association Privacy and Information Security and Healthcare Section Councils.
Well, thank you so much, TJ, and thank you to SIU Medicine's PSP, SIH, SIU School of Law. Thank you to Dr. Cruz, to Dr. Jean Basanta, and the audience that's with us through the end of this day. So thank you as an audience for being here in person, those who are here virtually. I appreciate the opportunity to speak with you and be part of this tremendous learning experience today, and to see colleagues and meet people in person who we've crisscrossed paths on a number of things over the years. So thank you again for the invitation. So we're going to talk about rural opioid use, where we are now, and the path, indeed, paths in the plural going forward, because a lot of different people and a lot of different ideas need to come forward and are coming forward now. And our communities all have different needs, and the needs evolve over time. I have no disclosures, except to mention any opinions expressed are personal opinions and do not reflect the position of the Office of the Illinois Attorney General. Going to show us our guideposts going through this final session. We're going to talk about national and Illinois opioid data, rural opioid use, legislation, Illinois Attorney General constitutional powers and duties. What does our office do? The 3 Illinois opioid settlements that we had this year, and where the money may go to help abate the problem in Illinois, current initiatives, future potential initiatives, the Illinois Prescription Monitoring Program, and drug take-back days. So we've got a packed agenda to finish. So most of you in the room know, and those joining us virtually, that unfortunately amid the pandemic, we had a sharp rise in deaths due to opioid overdose. At the end of, this is a statistic of November 2021, that the previous year hit a terrible milestone of loss of over 100,000 lives to drug overdose. Some statistics from the CDC: overdoses are the leading cause of injury-related death in the United States. Between 2019 and 2020, drug overdoses increased approximately 30%. Among the drug overdoses in 2020, about 75% involved an illicit or prescription opioid, 62% were synthetic opioids other than methadone, primarily fentanyl. The deaths involving multiple drugs have increased over time, and we'll see some of those statistics. And finally, as we know, these drug overdoses impact the individual, the family, and the community as an echo for many years to come. So as one guideline, we can look to some of the CDC's plan, and these are their recommendations in prevention of overdose and substance use related harms. And I'll take a moment to simply say that part of what we're doing and part of what as we go forward is to consciously use words such as substance use disorder and the DSM and the destigmatization of and medicalization of treatment, so people have a sense of greater access and treatment within the system. So some of the guiding principles are to promote health equity, address underlying factors, partner broadly, and we're going to talk about some of those partnerships, often across state governmental, state federal, state and nonprofit and charitable organizations, take evidence-based action, advance science, and drive innovation, which you've heard quite a bit about today, is the need for innovation. What are the strategic priorities? to monitor, analyze, and communicate trends. So we look at data and humanize the data, build state, tribal, local, and territorial capacity, support health providers, systems payers, and employers, partner with public safety and the community, and raise awareness and reduce stigma. And I humbly would probably, if these go on priority, flip it so that reducing stigma is first, because it shadows people's sense of ability to come to the system, feeling as though they're valued in the system, and need to really consider this as a medical diagnosis for which we help people. This is a 12-month ending provisional number of percentage of drug overdoses. The left-hand side is January 2015 through January 2022, and you see the steep rise, unfortunately. On this, we see the percentage change between May of 2021 till May of 2022 from the vital statistics. The light blue are those who are negative, so fewer deaths between that time than you might expect. If you look at Illinois, sort of the tan middle color, overall, the United States had a 13% increase in drug overdoses in the span of time. This allows you to toggle over each state individually, and this shows, and I apologize for the small slide, but Illinois increased the 13% in that 12-month window of overdose deaths. Now we're going to have some statistics from the Illinois Department of Public Health, and I want to personally thank them for all the work that they do in generating all the valuable data, and their epidemiologist in particular want to thank all of the team that is there. This is the report they generated just in May of this year and the data that they have therein. And Leslie Wise and her team is extraordinary in the work that they do. So if you look, it's the number of fatalities, total individuals, 2013 through 2021. You'll see a little star on these slides. The data is no longer provisional. These are the final numbers. When it was published, these were provisional. So these numbers do stand. And you'll see that between the last three bars, the third from the left, is 2019, 2,219 deaths, then a sharp rise in 2020 to 2,944, and again in 2021, a rise to over 3,000 deaths in Illinois. This charts monthly fatalities in Illinois. The blue is the individual, the red dotted line is an average going across months. We began by saying that the majority of the overdose deaths are multiple drugs besides opioids that are in people's systems. Of the fatalities specific to Illinois, the majority had an opioid plus another substance, 1,789. Of those substances, the most common secondary was cocaine. The third was more than, so in other words, three or more substances or multiple substances, alcohol in combination with opioids, benzodiazepine, which, as you know, both are respiratory suppressants and can cause death in combination. And finally, psychostimulants such as methamphetamine, which unfortunately is on the rise in its use. This graphic looks in Illinois at 2021 by race, ethnicity, age groups, and by sex. Of the total number of deaths, the majority were amongst non-Hispanic whites. But if you look at the fatality per capita, you'll see that amongst the non-Hispanic blacks, disproportionately high number of 60, nearly 61, compared to the group that is the highest is 20.5. So there's a disproportionate impact. Amongst the age groups of 25 through 64, there's a fairly similar breakdown of overdose deaths. Less than 25 and over 65 are fewer in the year, and significantly more men died from drug overdose than women. We've seen several of these maps today, which are sort of helpful for us to see what's going on in the whole state by county. And so as the saturation of the blue color becomes darker, the fatality rate is unfortunately higher. So if you look at the darkest on the map, and it's a little hard to see, so Cook County, Winnebago, Livingston, Iroquois, Greene, Calhoun, Montgomery, Union, and others on their borders had significant numbers of people who died. This looks at the non-fatalities, those who went to emergency medical services and the emergency departments and got care between January of 2020 at the left and December of 2021, at the right. The gray, largely the top number, are the emergency department visits, and the blue are the EMS care calls that were had. You see a bit of a decline in the beginning of 2021, but the rates are quite high. And here we see a combination of the data. So we're looking at age-specific data in populations of 100,000 and going the youngest age is at your left and over 65 is at your right, and by racial group. So the gray column at the far left is non-Hispanic white. The blue is non-Hispanic Black or African American. The green is non-Hispanic other, and the far right shows Hispanic Latinx. And in every group except the 25 to 34-year-olds, you'll see that the largest group of individuals affected are African Americans. Profoundly so when you look at the 45 to 54-year-olds and the category of 55 to 60-year-olds. Yeah. We've seen this slide for Dr. Hinkle a short time earlier, showing how over 150 hospitals that are rural hospitals closed between 2005 and 2019. This is an overhead map from the same center at UNC, University of North Carolina, and you can go in and look at this map, and I've chosen for us to look at closures by rurality, by which they define the green as large rural hospitals, the yellow small, and the blue isolated rural hospitals from 2005 to present, and you'll see the map of Illinois there showing where the closures are. We've seen this slide from Dr. Hinkle, so I'll go past these. The impact that it has, the closures to the community, to the connectedness to healthcare. What this slide is depicting is the GAO, or the Government Accountability Office, looked at a study of those hospital closures between 2012 and 2018 to see how far did the average person need to travel in 2012 versus how far they had to travel for specific services in 2018. And you see in miles, it's significantly more in those green vans showing how high you had to travel. Of note is for the left-hand side is general inpatient. The next over is emergency department. The next is the alcohol or drug treatment. And finally, the coronary care unit. So you'll see that the column for alcohol or drug treatment programs, as they choose to call them here, are profound in how far people have to travel. And we're a long state. We have vast distances. This is an average throughout the country. We're having people travel incredibly far distances, and the ports of call for people often are for treatment, the emergency department, and then hopefully to treatment and recovery programs. So what are some issues? And there are numerous issues, and some of these were sort of distilled down for talking with people who had lived experience and talking for people who work in the field. And everyone to the letter identified the overwhelming stigma that was given and apportioned to them. Be they not being rented somewhere to live, the extraordinary difficulty in getting employment, especially for people who have a criminal record, just transportation, and the other speakers have spoken eloquently about the challenge of getting to care. I mean, I live in a big city, and even in the big city, people coming to my office, it'll be very common that people take 3 buses and have to arrange. I encourage people to bring their kids to the office. I kind of like that. But if you think many people have to arrange childcare, and the extraordinary distances we're increasingly asking people to travel and to pay for, because all of those transportations have a cost as well as a time element. So there are so many people in this sphere doing extraordinary work, both at the state level, in the community. I've chosen but a few to sort of spark our conversation, and hopefully beyond this conference, we'll continue to interact and talk about each of these topics. So I'll begin by talking about the Illinois Health and Human Services Division of Substance Use Prevention and Recovery that mercifully goes by the acronym of SUPR, S-U-P-R, to sort of speed things up a bit. Extraordinarily people doing outstanding work. So one of their programs is the Access Narcan program. Whenever possible, I've used sort of generics, but the program is called Narcan instead of naloxone. And the program works with community organizations, hospitals, and clinics to provide Narcan directly at no cost. And their estimates and their tracking of their portal of those who have used their services between July 1 and 2021 and June of this 24th of this year is just within that short of time, the administration of 2,616 vials and uses of Narcan, that they've trained over 28,000 people to recognize the symptoms of overdose and to use naloxone for their treatment. And they've distributed in that short amount of time nearly 90,000 naloxone kits. Additionally, SUPR's work is in the education sphere. With their supplemental block grants, they have been part of and partnered with programs for education in the schools, ages 6 through 12. And with their newest grant, their direct school services are reaching to grades 4 and 5. And thus far, they have 19 organizations throughout the state that have signed on for this education. And their curriculum has at least one module that is specific to opioids. In addition, SUPR has applied for a SAMHSA state opioid response or SOAR 3 funding to increase the FDA-approved medication for opioid use disorder, support services for opioid use disorder and stimulant use disorder, and the goal is to reduce unmet needs and continue this education and treatment pipeline. Additionally, we talked about housing and the difficulty accessing treatment. One option are recovery residences or recovery homes. And SUPR has, for the year to come, 2023, is apportioning $7.3 million in sustained payments to fund recovery residences. And very important, they have created guidelines for methadone in pregnancy for opioid use disorder. I've put the link on here for the guideline that you can get on their website, but you can also simply go to DHS's website. These are their best practices for methadone use amongst pregnant persons using methadone who are part of opioid treatment programs. It's extremely important because, unfortunately, overdose is now the leading cause of maternal death in Illinois. Pregnancy-associated deaths involving opioids have increased tenfold between 2008 and 2017. I'm going to move to some recent laws passed in Illinois. This was enacted in August of 2019, the Overdose Prevention and Harm Reduction Act, of which I'll highlight really just 2 points of this act. And it's Section 5, the Needle and Hypodermic Syringe Access Program. So any governmental or non-governmental organization, including local health departments, community-based organizations, or a person or entity that promotes scientifically proven ways of mitigating health risks may establish and operate a needle and hypodermic access program. And it enumerates what are the requirements and the objectives. The objectives are to reduce the spread of HIV, AIDS, viral hepatitis, and other bloodborne disease, reduce the potential for needle stick injuries, and facilitate connections to evidence-based treatment. Part B under the same sections talk about programs established under this act shall. That's the lawyer in me. I highlighted the shall. You must provide the following services: disposal of used needles and hypodermic syringes, to provide the needles, hypodermic syringes, and other safer consumption supplies, educational materials and training, access to opioid antagonists for the reversal of opioid overdose, linkages to needed services, including mental health treatment, housing programs, substance use disorder treatment, and other relevant community services, and individual consultation from trained employees. It's a very comprehensive approach through legislation. And there are 2 if feasibles that I'll mention in the legislation and then the act now. One is a hygienic separate space for individuals who need to administer a prescribed injectable medication. We'll conclude by talking about safe injection sites. And finally, access to on-site drug adulterant treatment supplies. And what does that mean? Section 10 explains it a bit further. Dispensing of drug adulterant testing supplies. So a pharmacist, physician, advanced practice nurse, or a physician assistant or their designees may dispense drug adulterant testing supplies, or better known as fentanyl strips. And the quantity of that is limited to no greater than necessary to conduct 5 assays. This is part of a harm reduction in the sense that if one gets an illicit drug, it allows one to look if the presumed oxycodone has fentanyl, which is profoundly more powerful than morphine and has caused so many deaths. So people can use the strips, and hopefully if they find fentanyl, or hopefully even if they don't, allow people to think before they take whatever it is they're contemplating taking, and to contemplate getting to recovery programs. So this you can find on the CD's website, Fentanyl Strips, a Harm Reduction Strategy. And what it shows below in the strips are that when one tests, and they actually have the breakdown step by step on the website as to how one does that and combines the product with some water. A single red line is a positive for fentanyl. The dual lines, the double lines vertically on the bottom that are shown are negative for fentanyl. Are there false positives and false negatives? Yes. And you can read a bit more again on the CDC's website. So I'm going to turn with a bit of background to what exactly does the Office of the Attorney General do, and talk a bit about the opioid settlements. It's I think perhaps a rather unique. The Attorney General's office is very involved, and the Attorney General has a great interest in health and health equity. His father was a physician. His wife is a physician. My father was a physician, so we all come from a background steeped in healthcare and an interest in our community. So the Office of the Illinois Attorney General was established when our state was established in 1818, and the Attorney General is an officer in the executive branch of our state. Under Section 15 of Article 5 of our Constitution, the Illinois Attorney General shall be the legal officer of the state and shall have the duties and power that are prescribed by law. The General Assembly sets forth duties and responsibilities in the section quoted there, 15 ILCS 205/4. There are 15 enumerated duties. I will highlight but a few. To appear for and represent the people of the state before the Supreme Court in all cases in which the state or the people of the state are interested. To institute and prosecute all actions and proceedings in favor of or for the use of the state, which may be necessary in the execution of the duties of any state officer. To consult with and advise with several states' attorneys. To investigate alleged violations of statutes. I put parenthetically the Consumer Fraud Act. The General Assembly has given specific duties, and the Consumer Fraud Act, which here is given 815 ILCS 505/1, is the background for when you see these opioid cases, and they vary from state to state, but it's the deceptive, holding out, misleading, et cetera, of the public, and that is sort of the basis is consumer fraud generally in these opioid cases that I'm going to discuss. There can be others in other cases, in fact. And finally, the Attorney General can convene and prosecute under his own statewide grand jury. The first of the cases settled this year, after some years of work, the last 3 years at least, was the National Opioid Settlement Agreement, and this was across several states and several jurisdictions. Over 400 state and local groups were part of this combined effort. $26 billion are part of that settlement agreement. This is a press release from February of this year. It was against 3 pharmaceutical distributors, Cardinal, McKesson, and AmerisourceBergen, which are the 3 key in this country, and manufacturer Johnson & Johnson. This is the second largest multi-state settlement in U.S. history. The first was the tobacco master settlement some years back. And in Illinois, more than 290 Illinois government subdivisions joined. I'll briefly quote from the press release. The Attorney General Raoul's office negotiated the Illinois Opioid Allocation Agreement to ensure the funds Illinois received through this and any future settlements are allocated equitably to counties and municipalities. So another thing that's happened is that the remediation fund will largely go into a repository for abatement programs throughout the state. And instituted is the Illinois Opioid Overdose Prevention and Recovery Steering Committee, which will make recommendations for the equitable distribution of these funds. And the committee is to consider these, not limited to, but including population, opioid usage rates, opioid overdose rates, and the amount of opioids shipped to the region. So under this settlement, the national settlement, Johnson & Johnson is required to stop selling opioids, not fund or provide grants to third parties for promoting opioids, not lobby on activities related to opioids, and share clinical trial data under the Yale University Open Data Access Project. And if you've not looked at the Yale project, I commend you to do so. They do extraordinary work there in the project. That is Johnson & Johnson. For the three distributors, Cardinal McKesson and AmerisourceBergen, in addition to the financial settlement that was agreed upon, they must establish a centralized independent clearinghouse to provide all three distributors and state regulators with aggregated data and analytics about where the drugs are going, how often, and eliminate any deficiencies in the system of tracking from manufacturer, from the distributor to the end source. Data-driven systems must be used to detect suspicious opioid orders from customer pharmacies. What is a suspicious order? It could be an unusually large order of opioids. It could be very short in time orders, ones that should be tracked and detected as being suspicious, for example. They should terminate customer pharmacies' abilities to receive shipments and report those to company state regulators where certain signs of diversion are occurring. What is diversion? Diversion essentially means that the product, in this case, an opioid, doesn't go to the end source it should be going to. It makes its way somewhere else. And prohibit shipping and report suspicious opioid orders. Prohibit the sales staff from influencing decisions related to identifying suspicious opioid orders, and requires the senior corporate officials to engage in regular oversight of anti-diversion efforts within their companies. So moving on from the national settlement, we also had a settlement the Attorney General did with the opioid manufacturer Teva. The agreement is for $4.25 billion across the states that joined in the settlement. According to, I'm reading from the July 26, 2022 press release, according to Attorney General Raoul and the coalition, Teva promoted potent, rapid onset fentanyl products for use by non-cancer patients, deceptively marketed opioids by downplaying the risk of addiction and overstating their benefits. In fact, Attorney General Raoul and the coalition said Teva encouraged the idea that signs of addiction were actually pseudo-addiction, which should be treated by prescribing more opioids. The coalition also said Teva failed to comply with suspicious order monitoring requirements along with its distributor ANDA. So within this agreement, cash will be provided to the states over 13 years' time. And as part of the agreement, the states actually have an option, rather uniquely, in some of the choices in the settlement. And one is the amount of the settlement already agreed upon additionally can have those participating states may choose to have $240 million in cash in lieu of product. So in other words, Teva will provide states with either up to $1.2 billion worth of generic naloxone over a 10-year period, or $240 million in cash in lieu of the product, depending upon which state elects. Teva manufactures the fentanyl products Actique and Fentora, as well as the generic of oxycodone. And the final settlement is contingent on the agreement of critical business and transparency requirements. I'll conclude, this is the third of the cases this year, is with the manufacturer Endo. So Attorney General Raoul announces $450 million national settlement with Endo, contingent upon Endo's bankruptcy proceedings. And this is from August of this year's press release. Attorney General's quote is saying, Endo's actions played a key role in the overprescription, misuse, abuse, and diversion of dangerous opioids that resulted in an opioid crisis. Endo is an Irish company, Ireland-based, with a manufacturing with a headquarters in Pennsylvania. And its Opana ER was taken off from the market. It had an alleged abuse deterrent formula, which did nothing to deter oral abuse, and in fact led to deadly outbreaks of hepatitis and HIV due to the widespread use of injecting the Opana ER. As part of this settlement case, the resolution being contingent on, as I said, final documentation and bankruptcy approval, the payments of $450 million over 10 years, Endo was required to turn over its opioid-related documents for publication online in a public document archive. And the Endo will pay for $2.75 million to preserve the archive. And finally, it bans Endo's marketing of opioids forever. So for the settlement we talked about, the national settlement, this is the governor's executive order, which came about explaining the plans in Illinois briefly for some of that money. The proceeds received from the opioid litigation creates the Illinois Opioid Remediation Advisory Board and the Office of Opioid Settlement and Administration. So the funding will go into abatement programs, which may include these, but are not limited to naloxone or other reversing agents that are FDA approved, medication-assisted recovery programs, services for pregnant and postpartum people with opioid use disorder, services for neonatal abstinence syndrome, a bridge or warm handoff services to recovery-oriented services, treatment of incarcerated people, prevention programs, harm reduction, and syringe service programs. So the things that we've talked about have a funding stream. So what are some other innovations in opioid use disorder? This is one program, and there are others elsewhere in the state, of MAR's medication-assisted recovery programs, which use FDA-approved medications for the treatment of opioid use disorder. So this is a pilot project of MAR now in Chicago, a pilot that launched in May. It's Chicago-based for the moment, with the hope that the data will provide information to go elsewhere and be applicable elsewhere. In 2019, there was a 52% rise in opioid-related overdoses in the city of Chicago alone. And this is a partnership between SUPR, the Chicago Department of Public Health, the Illinois Helpline for Opioids and Other Substances, and the Family Guidance Centers. So how does this work? So if somebody calls the helpline, and they're calling between 6 a.m. and 10 p.m., they will speak directly with a manager in the program. If you call after 10, but before 6 a.m., they will call you the following day. And patients have the option, 3 options, and they may go back and forth. They are not required to remain within their initial option of how they would like treatment. The first is buprenorphine home induction. The second is same or next day medication-assisted recovery appointments at the Family Guidance Center, with a choice of either a methadone, buprenorphine, or an naltrexone treatment guided by both the patient's desires and the clinicians, and meeting of the minds. And finally, connections to substance use disorder care within the community. So in addition, it's a very comprehensive program in that the MAR Now program connects people to community MAR providers, the pharmacies, mental health, harm reduction, and primary care providers. And the managers for the program provide free transportation, help enroll people in insurance, assist with access to the pharmacies, and have an ongoing program of charting follow-up. And I've listed the Illinois helpline, the 833-234-6343. And as Illinois is piloting projects, it's instructive to look at other states. New York City has its buprenorphine hotline, as does Rhode Island have its 24/7. The Drug Enforcement Agency, during COVID, loosened up a variety of regulations, and in this press release of June of last year, realized, and I'll quote from what they've written, improved access will benefit rural and underserved areas with limited treatment options, expansion of medication-assisted treatment, alternatively called recovery. And essentially what the rule does is, instead of you requiring to have an individual DEA registration at each site at which you are, in other words, if you have a mobile system, you only really need one at this point, which administratively makes things much, much easier for mobile units to get out into the community. I'll conclude some of these with talking about safe injection sites, also called supervised injection or consumption sites. The origin of these sites go back to HIV, and the first safe injection site was in 1986 in Bern, Switzerland. During HIV, the government saw that if they provided a safe place and clean needles, they could slow the spread of HIV. In North America, Vancouver in British Columbia, Canada, was the first to have a government-sponsored system in 2003. And amongst other states, Rhode Island is the first state to officially authorize safe injection sites, and their pilot project of 2 years started in March. New York City at this point has 2 on-point service sites, which are sites in which people can go, and it's not simply a site for consumption, but also somewhere where there are obviously trained people to resuscitate people if need be, to get people to recovery when they're ready, to assist with housing and insurance and primary care, and being really overall encompassing. They cited that between November 30th of last year and January 23rd of this year, the organization reported 114 drug overdose interventions. And a word about the prescription monitoring program. So the prescription monitoring program is an electronic database that collects, tracks, and stores reported data from controlled substances, those that are dispensed. And each state can choose which that they track. In Illinois, it's controlled substances 2 through 5 and special drugs of interest, so that healthcare providers and their designees can look back at the previous 12 months of what has been dispensed to people. And over 1,300 healthcare organizations are integrated, so their electronic record speaks rapidly to the data in the prescription monitoring program. And the Illinois PMP is developing their educational materials that they'll roll out. Thanks on a personal level to SIU for School of Medicine for doing tremendous work and looking at this data and analyzing the data of the PMP that provides us all as prescribers in this state with invaluable information. On a personal level, I would love to look at the PNP and see back several years, more than 12 months, because patients don't necessarily recall what's been prescribed to them of any kind. Life goes on and things happen. It would be useful to know that perhaps a few years back, there were substances that maybe we should talk about and start a discussion. And finally, another partnership was one that I was privileged to be a part of with the Illinois Department of Public Health and our office, which was to design a training video. And the way that that came about was that the Illinois Department of Public Health and I went to the residency program coordinators in Illinois and said, this is the data in Illinois at that time. What can we do? How can we help? And in that meeting of program heads, they said, we want a video. We want that video to be partly about prescribing practices and partly about the prescription monitoring program. And so that was a video we created, and residency directors in Illinois and dental and nurse practitioners and physician assistants could use this, and some chose to use it as part of their orientation or onboarding to their programs. It's also something one can simply look at their convenience, and would be great to also update at this point. And I'll conclude by talking about safe disposal of medications. And as we know, things get into our water table as well. And leaving things in the medicine cabinet allow other people to, be unsafe, or people to see what's there and come to harm, unfortunately. And I'll also mention that 2 days from now is the National Prescription Day Take Back Day. And so that between 10 and 2 on Saturday, and if you go to the DE's website, they will show which is closest to you. They will take your medications and safely dispose of. They used to do this once or twice a year. Additionally, throughout the year, this shows Will County and Cook County, but most counties, if you look on their public health sites, there will be drop-off sites that you can go during the year. Typically, they are at police stations and pharmacies, and you simply deposit your medications and they will be taken care of. I'll conclude by acknowledging the tremendous work that's been done by so many people. And we've talked about a lot of data and a lot of personal stories. And the work that is being done, in this case, this is from a great, I got cut off a little bit, but NPR story showing a physician assistant, Saskia Noel, and a patient in a mobile care unit in Ottawa, Canada. But people that are devoted to the care of patients and have the expertise. And I applaud, and we need the telehealth. But the touching and looking at another individual and understanding and respecting them and saying, I'm here to help, is immeasurable. And I've heard many people say that my family's disowned me. My friends think I'm a loser. I have a record and I'm considered a snitch, but if I come here, I feel safe and respected and I know I'll get help. And people need to be looked at as having a medical condition we can help them with, help people get back in the community. And also want to thank healthcare workers and acknowledge that we need to do more for the burnout that people have suffered as mental health workers and everyone during COVID. And I'm very excited by Dr. Hinkle's work because we need to train people in mental health, and also acknowledge that we need to have fail-safes with flexible schedules and acknowledge the stresses that are going on with our healthcare workers before they reach crisis point, and acknowledge it and find the safe space to appreciate the work they've done. Thank you so much for being a part of this great conference. I appreciate the chance to be here and learn from you and spend time. Thank you so much. Any questions? It's been a long, very productive day. I also, I'm going to advance it to the final slide. My email is here. Welcome people reaching out. We have amongst the many bureaus in our office, we have an outreach bureau. So we go in the community to see what the needs are throughout the state, and also to provide information for victim services, for people who can make healthcare appeals. So one of the functions of the Attorney General's Healthcare Bureau is largely if people have difficulty with insurance coverage, denial of coverage, the office acts as a sort of a mediator and has trained mediators between the patient and the insurance to help people file for appeals.
I noticed that there is a pretty large gap between when the safe injection sites were implemented in Switzerland versus when they came to the United States. Do you know what that cause was for such a slow progression?
That's a great question. The question is an excellent one. If things started in Switzerland in 1986, it took till 2003 to get to North America, and we're getting in. It's a combination of questions, and I think legislation, regulation, stigma, primarily stigma as well. I cited Switzerland, but Spain has had a program since 1991. Australia has a program. I think there could be other factors, but also I think too, sometimes when our cousins north of the border also, and admittedly it's a 20-year lag of time nearly, when our cousins north of the border take initiatives, we also look at things differently. But I think you bring up a great point, which is there's tremendous pioneering work being done all around the world. And the idea is to be able to use those ideas and, if we can, modify them for all of our communities to be useful. Thank you. There have not been deaths reported in Canada at the safe injection sites, and they've had success in Europe and so on. One challenge in reading about New York site early on is people have had great assistance and great relief. The challenge is that it's not open 24 hours in New York, so that people are not able to come when necessarily convenient after hours. And unfortunately, in that setting, people are going to the public transport, the rail station. And in that case, so the idea is that to have systems that are comprehensive, and also when you're to pilot them to try and anticipate issues. So it's a great question, and gave me the opportunity to say that we need to, pollinate across the borders and waters elsewhere to see what's going on. So thank you.
Thank you for the work that you do. The information here is mind-boggling. In regard to the delay, and I want to be very careful how I word this, but one reads that there's, let's say, undue influence, financial influence through lobbying from the pharmaceutical, and is there any pharmaceutical industry, is there any way that you can answer that question?
I think the question is that lobbying still is quite a force in the pharmaceutical industry, if I take it. I think some legislation has been in the past across the country as far as perks that prescribers could get and so on. Hospitals and educational facilities themselves, I think, have often taken the initiative to say whether or not they want detailing going on in the hospital. Some of it is each state also handles things differently, but if one is uncomfortable with pharmaceutical detailing, often it is the hospitals and academic institutions that are part of that. It depends on how things are structured. Certainly, additional legislation, if it's thought to be necessary, can certainly take place. And there are other things even within like the city of Chicago. And so regions have chosen to limit or to curtail detailing activities too. So I hope that answered your question.
I have my own question. How do we better engage jails and prisons to provide medication-assisted recovery in hopes to reduce opioid overdoses upon release?
TJ, that's a great question. How do we better engage the inmate population? And I was really gratified. My colleague Carolyn pointed out to me that SIU has a entire program and section devoted to that. So I'm eager to meet the people part of that program. Some jails, and I think Sheriff Dart on a personal level has done a remarkable job on many levels as far as treatment programs. And there are treatment programs in many of the jails in Illinois. Some of it's probably the financial ability to provide that. But the other is the key that you've got to have a link when people leave and go out in the community, because an overwhelming number of people, if you don't find a bridge to their recovery and a safe home to land and a safe next jaunt, what is going to happen? You've decreased the amount of the opioid, if it is an opioid in their system or other substance in their system, and now they are without. And so the cravings and all of the phenomena that occur if you don't get people to treatment, people will commonly overdose and die. So it has to be both within the population itself to have the programs, but to have that bridge and that place to continue treatment. Well, thank you again. I appreciate the opportunity to speak with you today.
Thank you, Dr. Anawis, for sharing your experience and the work that the Office of the Attorney General is doing. At this point in time, I'd love to invite Dr. Wiley Jenkins, Research Professor and the Interim Chair of the SIU Medicine Department of Population Science and Policy, to give his concluding remarks. Thank you.
All right, thank you, everyone, and I will keep my remarks to no more than 45 minutes, I promise you. No, thank you so much for sticking with us to the end. I mean, this has been a phenomenal talk, and hopefully now you have a chance to maybe unbuckle your seatbelts a little bit, because we have heard a lot today. And Dr. Anawis, I love that last slide you showed. We talk a lot about numbers. We had pictures of towns, we had graphs. But ultimately, so much of what we want to do really gets down to that person, that one-on-one person touch. And to your point specifically, part of my work is with people who use drugs. Huge, that social disconnect, that stigma that impacts so much of their lives, and the ability to feel like a person that's valued again is huge. And the work we do to engage and work with rural communities is huge, because they have stories, they have families, and so often we reduce it to an anecdote, we reduce it to a graph, but ultimately we all touch real people, and I think that's part of the stories that we need to tell. So we've heard a tremendous amount today. We've heard from Director Vora about the Illinois Department of Public Health. We heard him speak about the 5 Ds that are commonly experienced in rural areas. Heard a bit about the IDPH Center for Rural Health, which is a little bit new for me. We'll be following up later with that, as well as some of the new items they have, sharing Illinois stories, bridging the public health and healthcare delivery, health and all policies. We heard from Director Eggleston from the Department of Healthcare and Family Services about some of their new initiatives, about the healthcare transformation collaboratives. about the nursing home rate reforms, and just a lot of the interesting work going on from that. We had a very comprehensive panel on children's mental health covering a wide range of topics. And that was, I think, particularly interesting for me because I don't know that much about children's mental health. And just to hear the depth and the breadth of what's going on, and while some of it seems, oh yeah, that's probably seems true, it is nice to know there's evidence base between what we know. We know that there's evidence base for things to do. Not everything needs to be researched for new things, especially to Dr. Shear's point. So often we need to implement what we already know, and we need to do it consistently. And I think to several of their points, long-term. These can't be one-offs that just last for a 2-year funding period. We heard from Pat and Rex about rural hospitals and the critical part they play. I love hearing about that history, about the whole network came together. And so, I mean, it's not pretty sometimes, but it's good to know that lived experience of going through to figure out how to make something work in some ways makes tighter bonds. And I really appreciate the work that they do, the mission that they have, and really kind of the mission drive that they have to serve their rural areas and keep doing it. From Dr. Hinkle, obviously very enthusiastic about rural workforce, and I look forward to speaking with her in her new role now. I just learned that she was recently confirmed permanent. She had been interim for a year, and so it's very exciting what they're doing in Rockford, and we're looking forward to potentially collaborate to do something statewide, looking at not only rural workforce, rural education, but also rural research. I think there's a lot of opportunities with the partners in this room to do some new and innovative things. And then Dr. Anawis and the work she describes, so looking at the legal aspects, trying to get back something that was taken from us in the term of a financial obligation from a company is not that, it's better than nothing. It'd be better if it had never happened, but at least we can maybe do some good with this, repair some of the damage. But obviously, the long-term impact is going to reverberate, past our generation. And so I applaud the work of the individuals doing that work. There's so many difficulties, and the aspects of stigma, the ideas of politics so often play into things that, whereas in British Columbia, it's evidence-based. They say, oh, safe consumption site, that's part of our universal health care, that's part of how we look at things. And it's not always that simple. And so British Columbia is truly a pioneer in this research. And so many of the things they have found have actually translated into U.S. policies in the past decade. And so we look for new good things with that. So with that being said, I do appreciate so much everyone sticking here. I do want to thank again Southern Illinois Healthcare, Southern Illinois University School of Law as being our two main partners in developing this symposia. They deserve a lot of credit for standing with us this entire year, helping develop it. I'd like to thank Heather Wetzel, Amanda Fogelman, Visser Chaudhry, DJ Albers, Tracy Johnson, Carol Caniglio, and Aaron Ham at the Department of Population Science Policy. They put in, I don't know how many hours, a lot to help put this together, and that is hugely appreciated. We also want to thank the Office of Continuing Professional Development. For those of you earning CEUs, they were largely responsible for making that happen, so we do appreciate them as well. And also the Memorial Learning Center staff for hosting us from the AB. So again, thank you very much for your attendance here today. We appreciate your questions. If you have any questions or comments coming forward, by all means, direct them to me and our staff, and I wish you safe travels and a good rest of the day. Thank you so much.